And then as the workshop series was funded by the National Association of Science Writers, we're going to use their code of conduct for online meetings, which really just amounts to being respectful and communicating thoughtfully. If you have a question, putting it in the chat and not invading anyone's privacy and all of that good stuff. I just sent the link to this in the chat, so you can get over if you would like. And then send questions in the chat, and I will moderate the discussion when we get to the Q&A section. So we're going to have two presentations. Drew is going to talk about Bloomberg's vaccine tracker, and then Arielle is going to talk about different complexities of COVID data analysis with a specific focus on race and ethnicity data, which also is a really important topic when tied into vaccinations as well. And then I'm going to, as I mentioned, we're recording this, so I will send you all the recording later this week. And I'll also make notes from this session available that will go out in my newsletter this weekend, and I'll share it with everybody here specifically as well. Any logistical questions before we get started? All right, sweet. So Drew, do you want to get going?
Sure, I'd be happy to. So hi, everybody. My name is Drew Armstrong. I work at Bloomberg News. I have been here for about 10 years, covering healthcare for about a decade and a half. And I run the Bloomberg vaccine tracker, the top part of which you can see up on the one of the first slides here. So I just what I'm going to spend the time on the presentation today is giving a little bit of an overview of our vaccine tracker, but really spending some time talking about the data behind it, some additional resources we have, how to understand our tracker and other types of vaccine data that we use, and then being ready for some time to take your questions. I say this because, we view this not as just a news product, but it really is something we want to be a resource for journalists, for civic engagement, for accountability, and for public health. When we think about how various people are going to be using what we have here. I will also just emphasize, and we'll talk about this a little bit later, I did, titularly run this project, but we have more than 100 people helping us inside Bloomberg, and we've gotten some very important outside help in setting this up as well. So I'll make a little bit more of a nod to that as we go on. Just to talk about what the tracker is and how it works, the Bloomberg vaccine tracker, we attempt to capture every vaccine dose for COVID-19 that's reported every single day around the world. We began in December with actually we launched with a database of vaccine contracts, deals that countries were making with vaccine manufacturers to acquire vaccine for their populations before vaccinations actually began. And then when doses started being administered in mid-December, we do a daily update every day around 5 or 6 p.m. with the vaccine numbers from the last 24 hours. Our data is pulled from primary sources. For us, that means government dashboards in states and the federal government, like the CDC, country level dashboards, outreach that we do to government officials. Some states have very, very sophisticated dashboards. Other places put stuff up on Twitter or in press conferences. Anybody who's dealt with COVID data is very familiar with this type of data environment, but it is basically equally as messy as a lot of the COVID testing and hospitalization data that I think a lot of people are familiar with. If we can move to the next slide, please. So what sort of data do we track? We basically look for like comparisons across different data categories so people can see what their state or country reports and be able to compare it to other jurisdictions. So that means things like the number of doses administered, people who have had partial vaccinations, people who've completed vaccinations, aspects of the vaccine supply chain. We actually just today, I'm so proud of the group that did this, launched a new vertical on vaccine demographics. If you go to our trackers page, you will see a new menu at the very top. There's some fantastic data that we plan to update on a weekly basis on race and ethnicity and vaccination and how states are doing, as well as state data quality. It's an unbelievable resource. And I'm glad that we'll be able to talk about that a little bit today. Basically, and then in addition to that, we have other aspects that we're kind of adding all of the time on the supply chain, those contracts, and trying to kind of evolve as the vaccine data landscape did. One of the things that we say is that in terms of how we collect our data, I talk about how we do everything by hand. This data, and I'll say this over and over again in this presentation, this data environment tends to be very, very messy. We'll talk a little bit about how state dashboards and other data sources differ a lot. Categories tend to be different. States and countries define things differently. And there is a huge onus on understanding the data and actually doing a tremendous amount of outreach work to figure out, does this mean what I think it means? And does what something means in New Jersey mean the same thing over in New York? And often the answer to that will be no. And we can talk about that in a little bit more depth. I would also be, we also do a tremendous amount of conversation with CDC and country governments. A lot of that is done by our outreach team that helps do this. If we can move over to the next slide. As I mentioned, one of our desires is to be a resource to help other people follow this information, helping news organizations and citizens. Every time I put up our daily update on Twitter, one of those things I see, as happened a lot early on, was people would tag their governors and yell at them, why is this not going faster? It can kind of seem like a little bit of Twitter polemics, but at the same time, it actually tells us that people are looking at this and reading it as a way of holding their elected and appointed officials accountable. One of the things that we've seen from this as well is that reporting on this data and presenting this data and doing the outreach to states and asking them about their data helps make the data better. We see a lot of positive feedback loop where when we report on these things and put them in our tracker and do the work to try to understand them, states and governments do a much better job of making that data clearer. And we think that there's a very positive echo effect in both us doing this and then other people jumping in and doing the same thing as well. I think that's actually quite important. If we can move to the next slide real quickly. Where our data comes from, we use a blended data model. We pull data from CDC as well as state dashboards. We tend to report the higher number of those two under the logic that vaccinations are basically a one-way street. You can vaccinate people, but you can't really unvaccinate them. And so if the numbers are going up, we treat that data as more recent. There are some rare exceptions to that when we think there might be a data problem or a potential data error, in which case that's one of the reasons why we have people review this every single day. Countries, many countries have actually launched their own vaccine dashboards of varying levels of sophistication. One of the things I think we've learned internationally is that if you think that the kind of data environment in the US is weird and messy, well, just wait till you go abroad. It's very standard for countries to report vaccine data over Twitter, on Facebook, just through press conferences that happen. China reports things about every 2 weeks when they dump out, a couple tens of millions of doses worth of data, whereas, Russia reports things sometimes and maybe it's wrong. Other countries have dashboards that are just as good or better than anything in the United States. And so we see a huge variety of data and quality of data throughout the globe in terms of what we see out there. And one final thing here, I mentioned the large number of people who are working on this project. If we can just bump to the next slide here. way we're kind of organized is that we have a core group of about 4 or 5 people who really help run this project on a day-to-day basis. But then we have volunteers from around the newsroom, and this is basically our byline at the bottom of the graphic, who have helped do this. One of the things that I'll emphasize about this data is that it really just takes a tremendous amount of work to collect this data and to understand it. That really requires a massive effort of people. A lot of times, I know there are other places that do automate some of this data collection. We have looked into ways that we think we could be more efficient, but have generally shied away from moving toward an automated model, partly because I think one of the things that we always say is that, if you have to really get your hands dirty with this data to understand it. When we talk about the kind of different categories of data, the number of doses administered, people who've been vaccinated with 1 dose, people who have only been vaccinated with 1 dose, but maybe awaiting a second dose, people who've been vaccinated with 2 doses, how many doses have been delivered to states and what does that actually mean, manufacturer breakdowns. The categories of data around vaccination are kind of complex, always changing, and continue to kind of get worse as we go on, and harder to deal with. I want to move to the next slide really quickly to spend a little bit of time talking about where we pull some of our data from. So I've got 2 state dashboards up on the screen here. We have a Tennessee dashboard and the Maryland dashboard. This is just an example of the different types of dashes that we see. Almost every state except for a small handful have one of these at this point. And I want to walk through kind of some differences of these, because these sort of things are a good example of what it's really important to understand if you are looking at state vaccination data and want to be able to report on it better. So Maryland here, Maryland is on the bottom, Tennessee is on the top. Now, there are a couple of toggles in here that I wasn't able to include that hide some of the data, but we have a case here where Tennessee reports the total number of vaccines reported, which means the total number of vaccinations administered. Maryland reports the same thing, but they break it down into first doses and second doses. Tennessee reports something that's actually somewhat similar, but different in a really important way. They report the number of people who have gotten partially vaccinated and the number of people who've gotten fully vaccinated. And their data updates in a way that people come out of the first category that's in blue there and move into the second category in green. Whereas Maryland's data, the number of people who've received a first dose is kind of perpetually growing, and the number of people who received a second dose is perpetually growing, but people are not moving from one category to another. We also see other breakdowns in terms of some states report how many doses they've received and subcategories of those things. Some report doses that have been received to nursing homes, some don't. Basically, I put this up here to show you that things that seem like they should be standard across states and like you should be able to make easy apples to apples comparisons are really, really, really quite difficult to deal with in some cases. And if you're reporting on one of these things, one piece of advice that I would give to anybody is get on the phone with your state officials or people who understand this data and ask them to explain it to you. There are no kind of common data dashboard standards for states or for the federal government. Everyone's kind of making this up as they go along. No one's had to do this before. I think we're actually quite lucky to have benefited from some work that was done by the COVID tracking project. And they had been working very hard with states to kind of improve the state dashboards. So when vaccine dashboards started, we were lucky in that, states were conditioned to the idea that it would be good to have a dashboard for vaccines. That said, they were all kind of beginning from scratch at the very start with saying, okay, how do we define all of these things? And it's this perpetual process of working back and forth with them to say, what does this category mean? Well, we're reporting this thing on our dashboard. Does that mean the same thing that all of these other states mean? We think that there will be many more problems to come. Right now, we're in the middle of we're starting up an outreach process around the J&J shot. Many of you may know that all of the vaccines out there right now are 2-dose vaccines. So this breakdown, for example, in the Maryland dashboard dashboard of first dose received and second dose received makes a ton of sense in a 2-dose vaccine world. But we are about to enter a world that is a some 2-dose vaccine world and a some 1-dose vaccine world. And it's going to screw everything up for us. So we're in the process of a long and what I assume will be quite arduous state process of going state by state, asking them how they intend to report this stuff. The last piece I'll say about some of these dashboards, and another piece of advice I would say in terms of talking to your state officials if you intend to report or use this data is, recency and issues like lag. All of these data have limits. Data doesn't get collected, doses go missing. They might be doses that are wasted or just haven't been reported yet. We talk about demographic data. We have published, one of the key things that we published in our demographic tracker that we just put up is how good is the data we see from states. We see a tremendous number of states that actually have very limited reporting of demographic data. So state might have demographic data, but they might only have it for 10 or 20 or 30% of their vaccine doses. So, when you cite something or use some of these data, if you're reporting on a state or if you're using a consolidated data feed like ours, it's really important to be conscious of the limitations of those things in how you describe them. One last thing here, if we can move on to the next slide, just in kind of a ways of thinking about vaccine data. Our graphic is really meant to help people do a number of different things and kind of think about vaccine success through a couple of different lenses. The first one of those is the idea of the vaccine supply chain. Is vaccine being produced? Is it being purchased? The kind of production and acquisition of the vaccines that will be used. Thinking about it through an operational lens. Once those vaccines have been made, are they making their way from the places where they're made to the point of administration and going into people's arms? Those are metrics like number of doses administered. We think about things from a health standpoint as well. What impact on disease are vaccines happening? Do we get to a certain level of vaccination and begin to see an impact on the number of cases and hospitalizations and deaths? And then lastly, we think about it measuring success from an equity standpoint. One of the aspects of this kind of big picture data that we present at the state level, or number of doses administered, it can mask pockets of failure quite easily. And I think that's really, really important to understand when you look at big numbers on a state dashboard. That just means that if you've covered 60% of the population, that's great. But who are the 40% you haven't covered? And are they concentrated in one way or another? And looking at things like demographic data or identifying holes in the data and saying, here's what the data show us, but here's how big the kind of black hole in that data is. It's very, very important to look at things that your data or data we show or anybody else shows and say, what does this not tell me? And if it's something that doesn't tell me, is that an opportunity for me to go out and report and try to understand better? There are places where I think as a data provider and a data consolidator, we can show a lot of things, but we can also accidentally mask things like that. And it's something I'd ask people to be really, really aware of when you think about this. The last thing I'll say just in closing is that, I and the rest of our team that work on this, we exist as resources. All of our Twitter DMs are open. We have a methodology blog and an analysis blog. We try to write a lot and say a lot about our data. And for all of you who are on this call, we're here for outreach, in addition to doing events like this that Betsy has been so wonderful to set up. We're available for kind of one-on-one consultations and trying to help people better understand data. So you can always find me on Twitter or through some of our other channels to better understand this stuff. So thank you all so much. I really appreciate you being here, and I'll turn it back over to Betsy and Arielle.
Thank you, Drew. That was great. And now, Arielle, if you want to talk about more race and ethnicity data stuff.
Great. Well, thank you so much for having me. As Drew mentioned, there are so many challenges with data related to COVID. And so a lot of efforts have emerged to compile data beyond what's sort of reported from official sources. And those are great, but for reporters and the public, that can also be sort of more of a challenge because it requires a lot more vetting of each new source. So I'm going to talk a little bit about, if you want to go to the next slide, just how to evaluate data sources, and then a little bit of some tips on health data and putting data in context. And then I want to talk a little bit more about some of what Drew talked about the lack of data and when that itself can be a story. And just as a little bit of background, I work at the Connecticut Health Foundation, which is a private independent foundation focused on eliminating racial and ethnic health disparities. So we do a lot of work with data, and COVID has unfortunately put a spotlight on and magnified a lot of the issues we work on. Before that, I was a reporter covering health at the Hartford Courant and the Connecticut Mirror. Just really briefly, data is incredibly important and it's very easy to misuse. Can be intimidating, but it really doesn't have to be. So I hope you will come out of this both a little bit more cautious and a little more confident. So just really briefly, if you want to go to the next slide, please. Just some really basic tips about vetting data. And it's the same thing you would do with anything else as a reporter. Who's compiling it, who's funding it, how transparent are they about who they are? Are they telling you the limitations of the data? Can you figure out what their methods are? And, the more transparency, the better. I always like to be able to recreate their process, not that I could do it myself, but at least kind of be able to almost track the chain of evidence, so to speak. So are they gathering everything from a primary source, or is it something else? If there's more manipulation done or it feels more like a black box, I'd be a lot less confident. And there's some sites out there like the COVID tracking project at the Atlantic that actually provide their data for download, which is great. And an important corollary to all this is, and I think Drew is a great example of it, is that you should always feel empowered to ask whoever is compiling these sources any questions you have after you've kind of done your homework and kind of tried to answer anything from what's available. Right now with COVID and the challenges people are facing, it might be harder, to get a response quickly, especially if you're on deadline. But in general, I found that people gathering this kind of data really welcome it when people reach out with a question, and they're often very generous about explaining their work or even sharing additional details or insights. When people are taking it upon themselves to compile this and create a source for others to use, making sure people understand it and use it correctly really aligns with that same spirit and mission. So don't be shy about reaching out. So that's a little bit about basic vetting. Once you're ready to dig into the data, just a few things to watch out for. And the first really basically is, does it fit with similar data? If there are other dashboards out there that you can compare it to, that's kind of helpful to figure out if something's an outlier. The next, and I think Drew explained this really well, is to try to make sure you can actually understand from the beginning what you're looking at. And I always sort of think of it as, can I say it in a sentence? And it might sound really obvious, but it's very easy to go down a path of trying to make sense of the data and then realize you have some really basic questions about what it is, even as simple as, does the daily COVID case number that my state report, does it reflect how many people were tested yesterday or the day the test results came back? That kind of thing will help you a lot once you start writing it. And if you sort of identify it early, you might find some questions that you need to explore first. One thing that's really easy to get wrong or to not notice at first is the denominator. What's the total population being studied? So is this everyone in the state or is it a subset? Sort of broadly in health, you see this often on health insurance data and uninsured rates. Some data sources focus on people under 65 because so much of the population 65 and over is covered by Medicare. So that's an important distinction. With COVID, one place you're likely to see the discrepancy a lot is actually with schools. A lot of school districts now have dashboards that show the number of cases that are associated with the school, and there's a lot of variation in who's covered. So for example, some will lump everyone associated with the school together, some will break out students and staff separately. Some districts only show cases among people who are actually at the school in person. But if you want to go to the next slide, some actually will show cases among anybody who is associated with, who is enrolled with a school. So this is an example of a dashboard from a school district in Connecticut, and they list every school, the number of cases, but you can see it also includes students who are learning remotely full-time. So that might tell you something very different than if this were just people associated with the school. So, as Drew said, you have to be really careful about what each dashboard says, because they may not actually mean the same thing, even if they're using similar terms. And another thing that's really important with health data is age adjustment, to be aware if your data is age adjusted. Age adjustment is very common in health data, and it's useful when you're trying to compare rates of something, such as rates of death between racial and ethnic groups, or rates of disease by state. The reason it's important is that age is such a significant factor in health outcomes and diseases. So anytime you're comparing different populations, you kind of want to control for variation in age as much as possible. And I'm not going to get into the way to actually do that, because I don't know enough about statistics to explain it well. But the basic idea is that you weight the data by the age distribution of each population. And this was actually a really significant issue in Connecticut with COVID data, at least early on. The early data on race and ethnicity in COVID cases was not age adjusted. So the state's numbers appeared to show that Hispanic residents were half as likely to die from COVID as white residents, and Black residents were about 25% more likely to die from it. Well, at the end of May, the state started age adjusting their data, and it looked really different. The death rate for Hispanic residents was actually 67% higher than for non-Hispanic white residents, and Black residents' death rate was actually 2.5 times as high. And if you look at the next slide, it actually shows sort of more current case data with and without age adjustment. And the reason that the raw numbers in some cases are so different than the age adjusted data is that the ages of each group in Connecticut are pretty different. So the median age for non-Hispanic white residents is 47 years. For non-Hispanic Black residents, the median age is 34 years, and for Hispanic residents, it's 29 years. So making sure you know if your data is age adjusted or not is really important, particularly if you're going to be using data from multiple sources. So that's a little bit about sort of how to vet your data. I want to talk a little bit about putting your data in context. If you're looking at COVID disparities, for example, you might want to find out, look into some other things that might correlate. You could look at other conditions that are linked to COVID risks, such as diabetes, the risk for having a severe case. You might want to find out if Black and Hispanic residents of your state have higher rates of other conditions or more limitations in access to care or insurance. And there's some really great resources where you can find this kind of information. My favorite is from the Kaiser Family Foundation. They produce something called custom state reports, or you can actually generate them from their website. And you can search by health conditions, factors related to access to care, such as whether someone has a regular healthcare provider, healthcare coverage, all kinds of sort of demographic data. And you can look by state and compare states. They're very transparent about where they get their data from. It's very user-friendly. Another source I use a lot is the Behavioral Risk Factor Surveillance System, or the BRFIS. It's a set of health-related surveys that every state does, and I believe some countries do as well. And it's a great way to find out about the prevalence of different conditions. It's self-reported because it's survey data. Risk factors people have, and it is reported by race and ethnicity. If you're lucky enough to be in certain states, they may have something called an all-payer claims database, where you can actually track where people are getting care, what kind of care people are getting, or some states even have public reporting of healthcare quality measures and health outcomes by race and ethnicity. Minnesota does a really great job of that. Another really useful source that I've found is some life expectancy data that was put together by the Robert Wood Johnson Foundation and the National Center for Health Statistics and the National Association for Public Health Statistics and Information Systems. And there's a link to that here. I'll put it in the chat later. And that looks at data from 2010 to 2015, and it compiled life expectancy data by census tract. And you can download an Excel file for any state. So one thing I did when it first came out and I had some time was I downloaded the Connecticut file and then matched it up with a list of census tract by town, so that I was able to generate a list pretty quickly of where there were significant gaps. And we found that, for example, in one part of Hartford, the life expectancy is 68 years, which is compared to a wealthier town on the coastline in Connecticut, where it's 89 years. And that's been a really useful resource to go back to as questions come up, for example, about disparities in vaccination rates by town. And the advantage of Census Tract as well is that you can also find race and ethnicity data by Census Tract through the Census Bureau. So the last thing I wanted to talk about is when lack of data is the story. We often focus on the data we have for good reason, but I'd urge you to pay attention to the data we don't have, especially when it comes to race and ethnicity. And we've seen some really great reporting lately on that issue, particularly with race and ethnicity data and vaccination rates. I think we've started to see more places reported, in part, I think, because of the coverage. Early on in the pandemic, I was talking to a reporter about the state's COVID testing data. And she asked why so little of it included a person's race and ethnicity. And even the most recent Connecticut data I looked at yesterday, about 36% of cases have no listed race or ethnicity. And the question of why so much of this data is missing, I think, is a really good one. And for people who've been working on health disparities, it's really an issue that we've been trying to address for decades. And the reason is actually a lack of standardized collection and analysis of health data by race and ethnicity overall. So we have public health data showing that disparities exist, but in most places, we really don't have the data within the healthcare system that would allow health systems or government agencies to track these disparities on a more real-time basis. And there are a lot of reasons for this. So race and ethnicity are often not collected within healthcare. For many years, healthcare providers were told not to ask about someone's race or ethnicity. Even if it's recorded, sometimes the person who's entering the information in the patient's chart just will kind of guess based on their own observations, in part because it's not something healthcare providers are always comfortable asking about. It's not always something people are comfortable answering. And it just hasn't really been prioritized in health systems. So that's one challenge. And then even when that data is collected, in a lot of places, your medical records aren't shared seamlessly between providers. So just because your primary care doctor knows your race and ethnicity doesn't mean your test site or your specialist will have that data. And even if all of those problems have been fixed and you're in a system where that works perfectly, in many cases, race and ethnicity data, if it's collected, nobody's actually using it to analyze outcomes or to identify disparities. And we can't improve what we don't measure. If you have the data, you could see, for example, that a certain percentage of your hospital's Black patients are not getting the recommended screening or the recommended treatment protocol. And that kind of data can drive action. It's especially important because we know from lots of research that Black and Hispanics do receive disparate care, such as being less likely to receive potentially life-saving interventions. The good news is that collecting race and ethnicity data and analyzing it is doable. And there are some places that have made a lot of progress and are doing it well. The Henry Ford Health System in Detroit's one example. The state of Minnesota has been doing a good job. So my request to you is that if we ever move beyond COVID, as you're thinking about the lessons and what to cover after, sort of keep poking at the questions of what data is collected in healthcare and how it's used. Ask, the experts what they wish were being collected and why it's not. And there are probably some rich stories there. I mean, I think we've seen from COVID how significant the racial and ethnic health disparities are. And if we want to address them, we really need health systems to have reliable data on patients' race and ethnicity and to analyze it and find out where the inequities are occurring. So if we really want to learn from COVID and do better, it's worth asking, what's happening with race and ethnicity data. It can be a really good way into the many challenges of the healthcare system. So thank you very much. I'm happy to answer any questions.
Okay, great. So we have a couple of questions in the chat, but first off, I just wanted to ask both of you, Drew and Arielle, if you have an example of a state or county that's actually doing a really good job of presenting data. I know we've shared some bad examples, but if I were a reporter and I were asking my governor to do a better job, what's an example that I would point them to?
I actually think that South Dakota does a really wonderful job in terms of the vaccine data. They integrate a lot of the kind of complex things that we care about into their dashboard in terms of, series starts and series completions. we're able to, it's complex, but just without being over complex is what I would say. In general, the kind of characteristics of a good dashboard involve, a dash that's kind of planned for the long term for how data might evolve, that has a really specific and clear set of data definitions. Often some of these dashboards include a whole page of data definitions, which is frankly the most helpful thing. I think from our standpoint, we can really pick apart any dashboard, and if we can do it, any journalist can do this, when there's clarity around what stuff means. I think the examples of bad dashboards are things where there is no clear definition about what information is being presented. We know that, sometimes it's hard to get this data, it's hard to present this data. It's really a question of transparency is one of the most important things for us. And updating on a kind of regular time frame really helps as well. So.
Yeah, I would agree with all of that. Drew has a much more comprehensive experience with dashboards. I will say I was looking at different school dashboards, and I was pretty impressed with the ones in New York City, where you're able to search by school. They provide a lot of information, and they also provide historical data for the school. So that's one I would recommend looking at.
Yeah, I know I've written in my newsletter that New York has the best school COVID data of any state, because they're the only state that's reporting testing data, and one of, I believe, only 4 states that's reporting enrollment data sort of comprehensively for all of their schools, which is a very important thing that we don't have on a big level right now. Another question, mostly for Drew, is around disinformation and reporting of data on an international basis. Have you found any official sources that are misrepresenting facts, and how do you address that?
I wouldn't say that we've found sources that are misrepresenting facts. I think one of the realities that we have to deal with is that, given the breadth of sources we go after, we kind of have to, take people at their word. I will say we have had cases of perhaps over enthusiasm for the numbers. Russia's vaccine was financed and promoted internationally by the RDIF, which is basically like a Russian government-affiliated private equity fund that then goes out and does vaccine deals with other countries. And they put some numbers out that were misrepresentations of how many vaccine doses had been used inside Russia. And we actually had to go back and do a kind of significant data correction because of that. That has more to do with various Russian ministries fighting with each other over who will be able to present this data than it does, I think, any particular effort to mislead. And we were able to actually get the right information from them once we asked them about it. I think more problematic is a number of cases where countries, and this happens less in the US, but countries have done things like reported this is an estimated, they report an estimated total based on the number of vaccines that they've delivered to their providers, but they're not clear that that was just an estimate. And so we have cases where we think that, data may be wrong or overstated because of that. And we've had to go back to them and kind of push them to report, I think because of lessons we've learned in the US, that just because the vaccines went somewhere doesn't necessarily mean that they got used. So it's less about vaccine. There's a lot of vaccine misinfo, but the vaccine misinfo we have seen is not necessarily related to administrations.
Yeah, I think that's probably true in the US as well to some degree, where you have to do a lot of digging to figure out what the numbers mean, but that doesn't necessarily mean that the numbers are not correct. Yeah. And then another question for Arielle perhaps would be, do you have any recommendations of good sources to learn about age adjusting data?
Sure, I can put some in the chat. There are a lot of sort of pretty good explainers on sort of why it's useful and how it works. I'll put some links in the chat.
Cool. And then have either of you come across much zip code level data for vaccines? I know this is something that some states and cities are starting to do.
Yes, to a certain extent. We see county level and some, I think, zip code level data. One, I'll say that we don't kind of have the technical capacity to start collecting and presenting it. I think to do that, we would have to move I'd either have to hire, 100 extra people, which we're not going to do, or move to an automated model. One of the things I think we have found to be true is that, automation saves time, but it also automates mistakes. There's another provider of vaccine data out there that runs an automated model, and for a brief period of time was showing that 300,000 out of the 100,000 people in the U.S. Virgin Islands had been vaccinated. We don't do that sort of thing for exactly that reason, because we know as people we make mistakes. We don't want to take those mistakes and multiply them with a computer. I think one aspect that's worth keeping in mind, and back to some of the things that Arielle and I have both remarked on, is that the further down you go in terms of granularity and specificity, the more I think you have to be cautious about the quality of the data and the completeness of the data. We see this with demographic data where, doses administered kind of being the highest level, and then going down to first and second dose data, and then going down to demographic data. You have data that often tends to be incomplete. We may only have it for half of the vaccines that have been given. Likewise, I wouldn't be surprised if the same thing were true of hyperlocal data. And so that I would say that if you're going to use that data, you really, really, really want to know what your level of completeness is. If there are characteristics of how complete it is, where certain types of, you might have, if you're looking at a county, are some parts of the county better represented, or some types of people in the county better represented? That tends to be true with demographic data as well. It may be that richer hospitals or hospitals in richer areas do a better job of collecting this information because they're better staffed than do poorer hospitals in poorer areas. So really asking what is behind the data when you look at any of these types of data, I think is incredibly important, because the numbers may tell you a story that it seems like you could write something and say something and say, well, this is the data, this is what it says, so that's what must be true, when in fact you have to be really, really cautious about that, I think, and talk to the people who provide this data to better understand it, and make sure you're not accidentally going to, report things that are where you got the numbers exactly right and the story totally wrong.
Yeah, I know one example of that I can kind of talk about is with the COVID tracking project, which I volunteer for, and which compiles testing numbers. I think it was back in maybe May where we realized that the testing numbers that we were getting from every state were not necessarily reported in the same way, because there are actually different units that you can use for your tests. You can report it in terms of how many specimens, like how many actual swabs going up people's noses have been sequenced, or you can report it in terms of how many people have been tested. There can be differences in timing. And once folks from the project started asking these questions, we sort of had to caveat all of the data a lot more. I mean, it had been caveated already, right? But there's a sense in which when you start to ask these things, you realize that just because a state or a country is using the same words as some other source does not necessarily mean that they mean the same thing. And so looking for those definitions and asking those questions is always very, very useful. Another question we have in here is what technology or tools you both are using to both analyze and display data. You have any favorites?
Google Sheets and Slack. I am not I am the last person in the world who would claim to be a data journalist. I guess I am now officially because of this, but I benefit from the coattails of some very, very talented data people who are far more able to speak to some of the technical aspects of what they do, who can do things like code and engineer and represent data in a way. I'm mostly like when it comes to anything related to technical matters beyond Google Sheets and Slack, I'm much more like Queen of England than any kind of management or proficiency role.
Yeah, I'm afraid I'm about the same, spreadsheets and
I have graduated, I would say, from what I refer to as, and I'm going to steal a term from Alexis Madrigal, who was one of the co-founders of the COVID tracking project, reporter spreadsheet versus data spreadsheet. I refer to a reporter spreadsheet as, basically you're typing notes, and instead of a Word document, they just have lines around them. And you might be able to sort some of them alphabetically into actual management and organization of the data. And I do think that that is a really, really important skill for people to learn, especially with complex data sets. And one of the things that I think we have learned is, if you're going to begin a project like this involving people who are data proficient with you and planning for the long term from the beginning, and thinking about, if you're a written word journalist like I was when I started a lot of this work, approaching projects, any reporting project that you do like this, as a data project from the start, and involving people in your organization or outside your organization who can help you think about it from a data perspective, because it will make your life 10 times easier as you go forward.
Yeah. And I'm not seeing any more new questions in the chat, but people continue putting those in if you have any. One more thing I would ask is, do you all have any particular stories or topics that you think are undercovered right now in the realm of COVID reporting, COVID data specifically?
I'll let Arielle go first, but I definitely do have a few if she has a couple.
I would say the first that jumps to mind is, as I mentioned, race and ethnicity. I think on the bright side, we're seeing more coverage of that than I think I've ever seen in health coverage, which is really fantastic. But I think, one thing that can be explored is going a little bit deeper than what we're seeing in the numbers, and really looking at why. And, not just, what are the different rates of underlying conditions, but what are the reasons behind that? There are a lot of reasons that have to do with differential access to care, differential access to resources, disparate treatment within healthcare. A lot of people who study this are now very comfortable saying, racism is really the underlying factor. So I think the more we can see digging into that, I think that would be very valuable. I realize it's hard to do when you're on deadline, but when you get some time, I think there's a lot of rich stories to do there.
Yeah, I'll basically add, I'll reiterate one of the things I said earlier is, look for the holes in the data, because I think that's a lot where the stories are. I'll tell a personal aspect of this. We look at, one of the things that we collect that's kind of behind the scenes is how many doses have been delivered. And this is a CDC reported number. And there's this gap of, something like at any given time, 15 to 20 million doses that the CDC has said have been delivered, but have not been administered. And I have gone into like a, crazy making spiral of attempting to figure out where are these doses. And that's kind of my personal black hole of what's going on here, and trying to unpack little pieces of that as we go on, be it, through what's going on in the nursing home settings, or is it an issue of delivery? But one thing I'll say kind of more broadly is that, I'm just going to admit this, like, I don't have time to do all the stories that I would like to do in all of the places that I would like to do them. There are versions of these stories to tell about how vaccination is going, about who is getting vaccinated, who is not getting vaccinated, how the rollouts are going, how the supply chain is going in every state in this nation and in every country around the world. I would encourage people to treat our vaccine tracker and other data sources out there as like idea generators for how can I do my version of this story, because we don't have time to do them all. I wish I did. I wish I had 30 more people working on this project. I just don't. And I would really, nothing would make me happier than to see local and other national versions of people really digging into some of the data here and using that as inspiration for stories, and helping bring accountability and transparency to this process, be it around demographic issues, operational issues, whatever they are. There is a version of this story to tell where you are.
Yeah.
I would add also, there's been a lot of coverage recently about the debate about school opening. And it has sort of struck me, living in a state where many schools are open full time, that element has been missing. Sort of what can we learn from the schools that have been open? And we did speak about the limitations in the information that's reported, the variation in the dashboards. So definitely have some caution. But I do think that there's sort of, in some ways, there's some evidence gathering that could be done that's somehow missing from this debate. And I think some coverage could be very valuable.
Yeah, another question we have is around accessibility. So for Drew, what is your team doing to make the vaccine dashboard accessible to as broad an audience as possible? And for Arielle, how can public facing data promote information equity?
So the first thing is our vaccine dashboard is free. Almost all of our kind of data projects like this are free. I think we ask people to register after a certain number of visits to the site, like most of our business competitors do at the New York Times and the Washington Post and other places. But for those of you all who don't know Bloomberg as a business, we're actually a financial news and data company. Our main product that Wall Street uses costs about, I think, something like $20,000 or $25,000 a year or something like that. We offer subscriptions to the rest of our website. I think those are like $40 a month. So everything is actually quite expensive. And for us to make this free is, I think, like I've given probably some degree of indigestion to folks on the business side, but that has been a priority for us, and we will continue making this free. We are also in the process of making our data public facing. I was just before this call, we've been kind of having a perpetual 2-week-long data cleanup and a conversation over Slack. That's coming soon, and because I know we've gotten a ton of requests from people to be able to play with our data, to see our data and mess around with it. That is on the way. I'd hoped that it was going to be up today, but we're not quite ready with it yet. But we do want to make that available to people. And then, just beyond that, in terms of accessibility, like we do everything we can to explain what we do and how we do it, and to be transparent about it and to correct our mistakes. This is the most read thing we have ever put up on our website in the history of Bloomberg.com. So it seems that it is being accessed. So I don't know if that means it's accessible, but a lot of people do seem to be finding it. So, and the other thing I say, like, we are open doors to feedback. We have a feedback form that we read. We get stuff from all around the world, which is incredibly gratifying when I've been DM'd by the Foreign Ministry of Iceland that was wondering why we didn't have their data up. So we are truly an open door for feedback about our data, and love hearing from people, and love hearing suggestions, complaints, telling us when we get something wrong, which sometimes we do, and ways and things that they want to see or ways that they want to use it.
In terms of sort of the equity side of things, I think that the kind of data that's available is really valuable in starting to ask questions and try to hold health systems, state agencies accountable for making sure that distribution of vaccines or testing still do have some equity. And I think, and this is really where you get from the data to doing the sort of old-fashioned reporting. I think there's been a lot of focus on vaccine hesitancy in communities of color. I think what we're increasingly seeing is that the challenges are not necessarily as much hesitancy as they are accessibility, getting onto the website to sign up, getting a ride to the test center, sort of a lot of nuances. And so I think that, the data can be a jumping off point to start to make sure that people are asking questions about why you're not seeing the kind of equity that we should be seeing. And then to really dig deeper to figure out, what the challenges are, because if it's only hesitancy, that's one type of solutions. If it's hesitancy plus people want the vaccine and there are really concrete barriers to getting it, those are very different things. And so I think, we need to have the data to start that conversation, but then dig further to figure out what the challenges and solutions are.
Yeah, I'll quickly add, just on a technical level, I think it's really, or one sort of underreported aspect of COVID data that I've seen is accessibility of dashboards themselves. A lot of states have dashboards that can be very challenging to navigate, or challenging to, maybe you have to like scroll over a pie chart to see the number for a small category of people in a particular area. And the COVID tracking project a couple months ago put out some recommendations for like a good dashboard, which I'm going to just put in the chat here for folks to reference, because I think that's also very important, that you can just understand numbers when you see them. And since we are almost at 2, I think that was a great place to end it. I'm going to share my screen for another minute here to show you all next week's workshop, which is going to be starting at 2 p.m. Eastern. I staggered the times a little in order to hopefully make it so that as many people can make these as possible. And that one is going to be specifically on engaging with data providers. So we're going to have Liz Esley White, who is from the Center for Public Integrity, Tom Meager, who's from the Marshall Project, and Erica Hensley, who is a reporter in the South, talking about their work in sort of a similar format to this. We have a couple of presentations and then an extended time for Q&A. And as I mentioned earlier in the session, we were recording this. So I'll send out the recording and the slide deck by the end of this week, along with some notes, which are going to go out in my newsletter later on Sunday. Yeah, I think that's everything. Thank you all for being here. This was really great. Thank you all for the good questions. And I'll see some of you next week, I hope. Thank you.